Good evening, Dr. Sridhar.
Evening, sir.
Ladies and gentlemen, hi, I'm Sanjay Pinto. I'm a lawyer and journalist, but I'm here today in my capacity as a comparatively rookie caregiver with a lot to learn and therefore a lot to ask. Today, as we know, is World Alzheimer's Day, but for all of us, it really is every day. And our showstopper this evening is the man who is our rock, Dr. Sridhar Vaideswaran. It's one thing to be at the top of your game. It's one thing to excel in your field, and quite another to be always accessible. I think patience is in Dr. Sridhar's DNA, and everyone who's listening in will vouch for what I'm saying. So, Doctor, to cut to the chase, I know it's been a busy day for you because you had the inauguration this morning. Is there a cure for dementia, Doc, on the horizon, or can it only be managed with inevitable deterioration? The reason I'm asking is because not long ago there was a Harvard study on aducanumab, which monoclonal antibody that sticks to the amyloid molecule that forms plaques in the brains of people with Alzheimer's. So, is this possible sometime in the near future, Doc?
Yeah, hi, good evening. And thanks for the question. And yeah, it's been a busy day, and I'm really pleased to be here on the World Alzheimer's Day and taking on these questions. Even though I'm a little bit anxious, as I said at the beginning, about the questions, because I don't think I know all the answers. I'll try my best to answer the questions today. If there is anything that I'm not sure of, I will get back to you if I can find out answers to those. Regarding if and whether there will be a cure for dementia, I'm sure there will be. I mean, we have cure for many cancers right now. We have cure for some of the other degenerative disorders at this point in time, in rheumatoid arthritis and things like that, where we have disease-modifying agents at this time. So I'm sure we will have a cure for dementia. I'm hoping it will be in our lifetimes. If not, eventually at some point, we will get there at some point. So the focus right now, I mean, while a lot of research is happening at this time, and of course, as you know, there's a lot of work going on in the US and other high-income countries to look at a cure for dementia. I mean, as you can imagine, it does involve a huge amount of investment to research for cure, and it is kind of a huge undertaking. There's a lot of work going on at this point in time. But the focus I would recommend is at this point in time with what we have. As you say, there are things that we can definitely do to to reduce the burden of the illness, which we should be doing more of with what is currently available. And also in terms of preventing dementia, we know that up to 40% of risk for dementia could be reduced by things that we can do from our level. Either as an individual, there are things that I can do, and as any one of us should be doing. And also as a society that we should be doing. And also, and when I say society, it's something that we need to do jointly. And also we need to have some kind of a pressure on the government to do some of the things. Things like literacy, improving literacy has shown to decrease the prevalence of dementia. And that's a known fact. In fact, we know that by educating someone, a child, we're in fact delaying the onset of illness by a few years. And that few years is crucial. Even if you gain 1 year without dementia for a person, that's the kind of, that's going to be a huge change for that person, not just for the person, but for the society as well. And also other things like diet, exercise, managing other health conditions like diabetes, hypertension, those kind of things. Those are easy to do. I mean, when I say easy to do, that's doable. Rather than looking at some research that may come with a cure for dementia in the next few years. These are the things that we have right now that we should be doing to prevent dementia in ourselves from coming on, or to delay it if we can. And also things like interventions for dementia that are currently available and useful to get them started sooner. So earlier diagnosis, getting the intervention sooner, preventing many of the risk issues and the complications that come with dementia. If you can do that sooner, that will actually improve the morbidity for many of the persons with dementia and their families.
Doc, unlike cardiac or cancer markers, there are no real definite tests to diagnose dementia. Correct me if I'm wrong. An MRI may show age-related degeneration. The reason I'm asking you this is to give you an anecdotal account. An orthopedician saw a patient with his, and said, looking at his gait, said, "I think he's got Parkinson's." And then he said, if he's able to shave without cutting himself too much, then it may not be Parkinson's. Then a cardiologist looked at him and said, look, I think he's got Parkinson's, put him on Sindopa. The neurologist said, Sindopa can cause delusions. So don't give Sindopa. I don't think he's got Parkinson's. So what really are the warning signs, Doc, of dementia? And who is the right specialist to diagnose Alzheimer's, Parkinson's, vascular or Lewy body dementia? This is constant battle. Who should a person go to first?
Yep. There are markers for dementia. There are some other markers available right now for dementia. Unfortunately, they are mainly used for research purposes at this point in time, and they are quite expensive to do. It's not something which we can recommend or ready to use in our day-to-day practice. But there are markers which are coming along the way. In fact, in the US, I think they have already started using them for diagnosis.
What age, Doc?
Even earlier, even people in their 50s and early 60s who are presenting with mild memory problems and things like that, where we can, there are some sophisticated scans which can actually pick up the deposits of amyloid in the brain, and also the tau proteins in the brain. And there are also some CSF tests, doing a lumbar puncture and looking for some of the proteins in the CSF. And even some of the blood tests are around, and they're not actually definitive, but they are around at this point in time. So they are there for early diagnosis of dementia, but it's not come to the mainstream, and it's not cheap to do those tests at this point in time. Definitely not available in India at this point in time. So to look at early diagnosis of dementia, what single advice that I would give is, if you feel that for yourself or for your relative, if you think that something is not right for that person, go and get advice as early as possible. Don't wait, and don't dismiss things like it could be just because of getting older. That's a common thing which we hear in our clinic, is that we knew that things were starting 2 years ago, 3 years ago. We found something was odd, but then we thought it was just because of old age.
What are some of these odd things, Doc? I mean, memory loss is so common with old age. So it's often dismissed as a cognitive deficit. So what are those warning signs that a common man would be able to pick up and address immediately?
See, memory loss, as you say, is quite common. It's not just specific to old age. Even for us, even for younger folk, we can be forgetful if we are under a lot of stress, or if we have too many things going on in our lives at that particular point in time. If we're too distracted, we will be missing out on things. So that is kind of that can happen. And same thing can happen in an elderly person also, if they are under a lot of stress, if they're worried about things, if they are, undergoing some trauma or difficult situations, then definitely they will be a little bit forgetful or distracted. But having said that, you find that there's nothing big going on at a particular point in time, and still you find this person is being forgetful or being a little bit repetitive with their questioning or in their conversations. Some of the things that they did very easily before is taking a little bit more time. You are finding they're consistently making mistakes. They're consistently misplacing their glasses or their keys or wallets and keep looking for them. They're consistently saying that people are coming into their house and stealing their things, and it's kind of happening in a very, very regular manner. And if it's happening for nearly a month or two, then I would advise that you kind of get help and go for help as early as possible.
So do they go to a psychiatrist like you, or do they go to a neurologist or a general physician?
Anyone is fine. The point is, anyone who has experience working with dementia, like general practitioners are good, family physicians are good. And family physicians, in fact, know the person very well for a long period of time. So anybody who has some knowledge of the person, if it's possible, they'll be able to make a good assessment of that person. If not, an expert who has experience working with dementia. The common thing is, we doctors, the field has become very hyper specialized, unfortunately. So people are kind of focusing on, as a psychiatrist, you can be a child psychiatrist, you can be an adult psychiatrist, you can be a geriatric psychiatrist, or you could be, in Western countries, you have other further specialties, like you have special doctors for eating disorders, you have forensic psychiatrists, the list kind of.
India, I think you have neuropsychiatry, which is the latest fad.
That's right. So we have many such subspecialties, and not all of them are are well versed in it. Like, say, for example, if a child comes to me with ADHD, I do the basics of ADHD, but I won't be able to give them a diagnosis confidently or treat them confidently, because the last case of ADHD I saw was nearly 20 years ago. I don't see that patients regularly in my clinic. I think the same logic for someone with dementia. I mean, we can't keep up to date with the current knowledge. If you're not working in the field, you're not consistently seeing patients regularly, and you're not keeping up to date with the literature. So that kind of you kind of tend to narrow down and focus on one specific area. My area of interest is in elderly mental health and geriatric psychiatry and dementia. So I kind of keep up to date on that. So I know more about dementia. And likewise, people who are trained like me in old age psychiatry, they will be able to make a diagnosis of dementia easily. But there are also other good psychiatrists who make diagnosis of dementia and who see a lot of patients with dementia. That's also true. That's also happens. And similarly with the neurologists, you have neurologists who specialize in epilepsy, in stroke, and some of them specialize in dementia. So if you go to a neurologist who sees majority of cases as epilepsy, to go to them with the dementia, you may have a little bit of a lag in diagnosis and things like that. I'm not saying that they will not be able to make one, but to go to a specialist who consistently sees patients. Do you have neurologists who specifically only deal with dementias, specifically deal with, there are behavioral neurologists and cognitive neurologists who specifically focus on this. So we could go to them. Our aim eventually is that we have a better primary healthcare system. In fact, I would probably talk about this, or this is a good time to say this. When I was working in the UK, we actually developed a program wherein we started training the general practitioners in the community to identify dementia. I mean, they had similar issues when the last patient they had with dementia, proper assessment and things that they had done was a long time ago when they were in medical school or when they were in training. And since then they see other things, and dementia is not the only thing they see. So in a short span of time, to go to a GP who has only 10 minutes to make an assessment and come up with a recommendation. So how do you it's a judgment call. We need to make a call whether this patient has dementia or not, whether I should refer this patient to a specialist or not. I mean, that's the call that they need to make, and we equip them to do that. So there has to be a lot of training and awareness amongst physicians. And again, as I said, many people are not up to date with the literature. So the last time they saw a dementia patient, if it was 20 years ago, there wasn't much done for people with dementia. So right now we have so many things that are available. So the knowledge they have, maybe that they will say, I've heard the story that it is dementia, there's nothing much can be done. You just take them home and keep them at home. I'll give you some pills, just give it to them and that's it. Again, that needs to change. So we need to actually focus on training, raising awareness amongst general public, amongst physicians and other healthcare professionals, and also families. So that's also another thing. So to kind of come to your question, who should you go to? Go to someone who has experience dealing with dementia.
It's a common question. In fact, many caregivers have also raised this. Is dementia hereditary, Doc? And what are the high risk factors?
Dementia, a part of it is hereditary. Not all dementia is hereditary. The reason we need to, if you have to think about whether a person, I don't recommend genetic testing for all family members when they come to us. If the onset of dementia is early, if it is, say, when I say early, if it starts in someone in their 40s, 50s, even early 60s, then there is likely to be a genetic component in that case.
In such cases, the children would have a predisposition.
Yeah, their children who share the genetic load may share a genetic load for dementia. And then we ask for, if they wish, we could refer them for genetic counseling in those cases. Not all dementias are hereditary. Even in young onset dementias, not all of them are hereditary. So you may find majority of people, you don't have to worry. If you have a relative with dementia, you don't have to worry. If it is, if the onset is early and if your doctor thinks that this could be hereditary, then you may have to get yourself tested.
What about alternative healing methods like acupressure? Because we have in the caregivers group, there's an expert, Meher, who's doing great work. Do these help? To what extent do they help?
Definitely, they help. I mean, when you have multiple systems, multiple health systems, particularly in a country like India, where you have Ayurveda, Unani, the Chinese, they do have at some level they seem to work. The thing is, the problem with many of these alternative medicines is that we don't have robust evidence base. That is a problem. Many of these alternative medicine systems, and I think that problem is inherent with the way the health system is being practiced, and the kind of the rigor that you need to test them in our setting is very difficult to do, because as you know, any research needs a lot of investment to do it properly. If you want to generate evidence whether a particular intervention works in someone with condition, let's say
Large
dementia,
sample sizes.
yeah, you need large sample sizes. You need a very robust research, which means money. I mean, if you want to do a randomized controlled trial, it's going to cost you at least 30, 40 lakhs of rupees, even more maybe. I mean, I would probably put a budget of 1 crore to do a small scale RCT to see whether acupressure works for someone. You need that much amount of money to definitely say that this works.
This is
Otherwise,
where the
it doesn't.
corporate world can come in, doc. I mean, you have the corporate social responsibility. You have a budget for that under the Companies Act. So maybe hospitals or big pharma companies can probably foot the expenses for these for research of this nature.
They can and they should. I think we need to see more of those kind of collaborations and things that should come through. So yeah, definitely.
Now, another common concern is that most dementia patients who are perhaps 70 plus have a plethora of complications. They end up taking a cocktail of medications, like my father does. Now, many antipsychotic drugs to address their delusions may be a contraindication in some cases. I remember that you once mentioned to me that for instance, it might lower the white blood cell count. How effective also is the patch, the transdermal patch, Rivastigmine, in arresting the progression? Is it a sort of tightrope walk that we have to really perform here?
Yeah, I mean, medicines are always tightrope walk. Even simple paracetamol can have side effects. Can have toxicity.
Even I think Bicoshules, if you do a Google search, and then you're scared to take even vitamins.
That's right. That's right. So you need to be careful with any medicines. So prescribing any medicines should not be taken lightly. That's something which I keep telling all my trainees and my students. One of the rules in prescribing in elderly is that is it necessary? Is it absolutely essential? And that's the first rule that we need to actually pass. And often when I start seeing my patients, I start cutting down on medicines. If I can stop a medicine and doesn't cause any problems for them, they don't need it. On an average, any elderly person are on at least 8 different medicines. Okay, on an average, and many of them are essential. Like some of them might be for their heart conditions, their diabetes, for their blood pressure. Some of them needed for their prostate problems or for other things. So they are quite essential. We can't stop those essential drugs. But some of the drugs, maybe we could kind of either stop or reduce the dose of some of the medicines. And again, if you can choose between different drugs which are which are tolerated better or which are likely to cause less side effects, I think those are the kind of things that we should be choosing. So it's always a tightrope. The aim is to reduce as much as possible, and that's feasible. So that's something which we try and do. And any medicine that we start has to be prescribed at a tolerated dose, but it has to be effective. If you feel that, what I generally tend to do is to start at a very low dose and gradually build the dose over a period of time until they reach, they're able to tolerate it at a certain level. But again, we need to push the dose for it to effectively work. There's no point prescribing half measures because it's like jumping over a well and stopping halfway, and you're just going to fall in. It's not going to give you any benefit. So if you decided to jump the full way, but if you feel that it's not working or it's not, the person is not tolerating it, then you go back to the drawing board and try alternative options. So working with an elderly person, you need to actually have plan A, plan B, plan C, plan D. And when plan A works, fantastic. Plan A doesn't work, fine, don't lose heart. We have a plan B. Doesn't work, fine, we go to plan C. So we have multiple plans for when we look at a person. And your question about whether rivastigmine or drugs like donepezil, another drug which we commonly use is called memantine, meant as a treatment for that. These drugs do make a difference. There are lots of studies which show that they actually help to slow down the disease progression. And in fact, many of the studies in the Western countries have shown that these drugs actually delay, hospital admissions or delay, institutionalization of persons with dementia in those settings. So definitely they have an effect, but in terms of whether they cure the person of the illness, not. They don't do that, but they do make a difference to the person. Not everyone responds the same way. Some people show a better response than the others. I think the trick is in how early do we pick it up? How early does the person start on this medicine? So if we start them early, they do make a difference. The later we leave things, the longer we leave things, and the later we start the drugs, the effect may not be fantastic.
A slightly personal question, Doc. I mean, because anyone who interacts with you can really sense the passion with which you work. What drew you to cause of dementia? Was it someone in your family or a friend suffer from dementia?
Not at that time. My grandmother had dementia. She passed away, but that was much later, only in the recent past. I think I started working with dementia. Probably it started off when I was doing my post-graduation here in India, and I had a dementia patient as an exam case. So we had a practical exam. It was a mock exam before our actual exam. And I did miserably on that day, working up for a person with dementia. And, of course, I knew the theory, but I didn't know practically how to manage. And that's one of the things which needs to change, and I think it's changing. So at that time, I kind of wanted to know more about it, and I learned about it. Of course, after that, I passed the exam, thankfully. And then when I went to the UK, where I had an opportunity to work in old age psychiatry as a super specialty, and which I trained in that. And I kind of worked there. It's been no going back since then.
And there's a very insightful comment that is cropped up that companies may not be willing to actually fund research because they'd be actually cutting the grass under their feet in the sense that be losing out on business. Anyway, I won't put you on a spot and ask you to answer that, but then it's more of an aside. I guess there's a lot of truth to that. Doc, now a very real problem that most caregivers face, especially at the time at which it strikes, where when dementia actually comes to the fore within the family. People may be sandwiched between pediatric concerns, geriatric concerns, and their own middle-age blues. And many of them at the peak of their career would have to then rework their working arrangements. As an eminent doctor dealing with this, are there any tips that you can offer caregivers to manage their stress? One is managing dementia, but also the stress of caregivers.
Yeah, that's very important actually, because see, whenever there is a conflict in the roles that the person's responsible, there are, if you have a role as a father to your child, you have certain responsibilities that you need to be carrying out, and you have a responsibility as a son towards your father or mother that you need to be looking after them. And then you have roles as a profession. As a professional, you have certain responsibilities to your profession that you should be carrying out. When everything is going fine, things are okay, you're able to manage things. But when there is a problem in one, maybe you can manage to an extent, but when you start having problems in more than one areas, and this is something which we find in particularly in India, where most of the caregivers are women, and women, particularly when they are working, and they have more responsibilities to manage, and that does cause a lot of conflict within themselves. For how to manage these different roles, it causes a lot of distress in that manifests as caregiver burden and things like that. So there are lots of things which needs to be in place to help these caregivers. Now, the first thing is the person themselves. Starting within the person, how much can you improve your reserve to manage stress? I think that's something which we can't do it at that time, and that cannot happen then. It's something which people need to start developing from an earlier stage. So people may have hobbies, people may have go-to things that they may healthier coping strategies like exercise or music or meeting with friends, the socialization, spirituality, whatever that they can do.
All of which have taken a beating during the lockdown and the pandemic.
Of course. So many of those things people are unable to do now, and that has made a huge difference in how we manage things and how we cope with things, unfortunately. So those are things which can help starting at the personal level. And of course, at a personal level, again, when you feel that things are difficult to manage, seeking professional help is not a bad idea. It does help to manage your own affairs better, and also to help with your caregiving responsibilities at the same time. So that's something which I would definitely recommend. You can have professional counseling, even at a lower level, at a very light touch, counseling can help. It need not be formal sessions or anything like that. Just even with friends, even with family members, people who you can link up to, and sharing the responsibility of caregiving. Again, many of us assume that it has to be me, it has to be only me that who should be doing this. Probably kind of just sharing that responsibility to an extent with others who you can trust to carry out some of those caregiving roles and responsibilities. That's something which people need to start developing. And of course, managing other things like techniques like meditation or mindfulness. Those things help. And of course, when you go for professional help, there are other stress relaxation techniques which professionals can help you with. Simple things like I'm sure many of the caregivers may have been part of the START program, which is primarily looking at caregiver interventions and also self-care methods in caregiver intervention. In each, there are 8 sessions, and each session ends with a relaxation exercise. There are various levels of relaxation exercise, looking at imagery, things like signal breath, and things like that. Mindfulness, bit of mindfulness is also there. So you could use components of that and see how you can relax. So that's at the personal level. The second level is at reducing the illness burden. So a lot of studies have shown that when you have a person with dementia who is having a lot of behavioral problems, especially with sleep, if they're not sleeping at nights, or if they are being very paranoid and delusional, and they are kind of accusing people of other their caregivers of things, or if there are increasing physical health needs, so they need to be lifted, or they are incontinent all the time, that increases the burden on the caregiver. So increased behavioral problem and increased dependency on the caregiver, these two increase the burden on the caregiver. So if you can actually have help at home, so you can employ a nursing assistant or an attendant to care for the person with dementia, and that should reduce the workload on the caregiver. So that should also reduce the caregiver burden to an extent. The other important bit is when there is a behavioral problem, things like that, again, managing that. So getting professional help to manage those behavioral problems can also help reduce the stress. The third thing, that's a much bigger thing about the society and about systems that there are. Caregiving can be a very lonely place to be. So, and again, others may not understand what dementia is and talk about, oh, this person is okay, why do you need a caregiver? If it was me, I wouldn't have admitted this person in the hospital. I would have done a better job than you. I mean, they will not say it directly, but that's a kind of implied message that many caregivers hear, and that's something which often they share with me. When you hear things like that, it's about lack of awareness amongst the community, amongst others.
To what would you actually attribute this lack of awareness, Doc? Because even to people who are reasonably well educated, to them dementia probably means loss of memory, not the other conditions. And part of the problem probably is perhaps because there are tricky signs that are emitted. Person has lucid moments, the person has those irrational moments. So many of these people who talk to those with dementia, talk to them when they're having a good time, a good day. They say he's absolutely fine. What are you saying? So they almost make you feel as if you are falsely accusing them of something.
That's right. That's right. I mean, the lack of awareness is because of there are too many things for people to know about. I mean, not all of us are going to be aware of everything that's happening around us. But to an extent, I mean, that's the purpose of this World Alzheimer's Month, the World Alzheimer's Day, is to raise awareness about dementia in the general public. Because I mean, so far, if you look at dementia, it has not been something which has affected a lot of people, you know, so far. But that's changing with many of us living longer. Almost each one of us at some point will be either directly or indirectly affected by dementia. Either it will be us, ourselves, or it could be someone very close to us, or someone living around us. It could be our neighborhood, it could be somebody who we work with, who we went to school with, or someone, okay, who has dementia. So that's where the things are going. So it means that people need to be aware of what dementia is, and how much and what it means, and when to seek help, where to go for help. I mean, those are the kind of things that we should be doing more of in the future. And I don't think just doing a program on World Alzheimer's Day alone is going to help.
Knee-jerk reactions really don't help.
Yeah. So just a one-off program doesn't actually make a difference. We need to do it more consistently over longer periods of time. And even then, it's going to, because people don't, I mean, if it's not bothering me, why should I know about things? And
Doc,
often people think,
sorry, No, sorry, I interrupted.
No, carry on.
Vitamin M is a big factor when it comes to caring for dementia patients. Because let's face it, it's quite a costly proposition. Do you feel the government should actually step in here? Because at the end of the day, I always believe we are a welfare state. We're a democracy, we're a welfare state. And the right to life includes the right to livelihood, duty towards parents. But for instance, there are many of these facilities which are actually real estate facilities which charge a bomb, a lakh and a half per month for take care of a dementia patient. Many of them don't even take care of dementia patients. We know of hospitals that don't admit patients with mental illness despite the law being very clear. Do you think the government should actually impose a cap on charges of, for instance, caregivers, agencies that supply, caretakers, and unless you earn enough, at least 50,000 to a lakh rupees a month just for take care of a dementia patient, and it's a vicious cycle. If you're not able to focus on your work, if you're not able to leave home, you will not be able to really provide for them enough. So it's a catch-22 here. How does one manage it? What would your recommendations be to the government?
Definitely more has to be done by the government. And that's the only way to sustain this, because private healthcare alone cannot sustain in the long run for everyone. And it's not something which, as majority of the population is not well enough to pay for, when I say well enough, both physically and also financially, to pay for their care for everything. Because what we need to remember is dementia doesn't happen alone in a person. Along with dementia, the person may also have heart disease, they may also have diabetes, they also have eye disease, other things, dental problems, which are quite expensive to treat. So we need to have a comprehensive plan for elder care, which is currently, I think there are a few policies which are existing, but they are not being implemented on the ground. I think that's something which we should be working on. Again, looking at dementia care, you're right that some of the agencies do actually charge quite a bit for looking after the person. But we need to understand that looking after someone with dementia is an expensive thing. We need trained staff. It costs money to train them, and for people to be sustained in this field of work. If I were to choose between looking after as a career, if I'm a nursing assistant or a nurse, I kind of look at start with I need to get trained for a period of time, and then I need to work with someone who sometimes is very difficult with me. Okay, so that is a choice. Or I could go and work in a supermarket for probably a slightly better money, and I'll have just have to deal with some customers and some colleagues, and adjust some shelves and be at the till and come back home for the same amount of work, and which is much more relaxing, not as hard as looking after someone with dementia. So if you want people to to come into this field, you need to pay them better. Only then you will be able to have good quality people. Otherwise, if you're going to pay peanuts, you're going to only get monkeys. So you need to actually pay them better to have better people to come and work in this area. So it has to be that way. That's the way our society.
And I guess even breaking the stigma also will have more people, draw more people to this field. One of the questions that I also that popped up on the screen is, is it possible to actually prevent dementia with the usual healthy diet, exercise, active lifestyle regimen for those in their 50s, probably entering the danger zone perhaps in the next 10 years? Is there anything they can do to prevent dementia? You actually addressed that earlier, but I think it's a question that I'd like you to focus on.
Yeah, we can definitely do a lot of things to prevent dementia. 50s is probably a little too late, but better late than never. We should be starting much sooner. I think their 20s, because the pathology starts much earlier. Know that some of the Alzheimer's disease pathology or even some of the vascular disease pathologies, they start in our 30s and 40s in our brains. They start accumulating over a period of time, and that's what leads to dementia at a later age. So, but better late than never. Even if you're in your 50, even if you're in your 60, you can start doing something now, and that definitely will reduce some of the risk factors. So regular exercise, proper diet, good sleep, socialization, keeping oneself cognitively engaged and stimulated, and things like that definitely make a difference. Stopping smoking, consuming alcohol at a very, very moderate level or mild level, if at all, and if you can avoid it best. And also looking at if you have hypertension or diabetes, managing that better, making sure that you're going for regular checkups and taking your medicines regularly. Those things matter. And also
even childhood trauma, or these things also are they triggers later in life? They surface later.
Head trauma, childhood head traumas, even road traffic accidents, helmets actually do prevent dementia later on. So there are studies which show that if you preventing head traumas do prevent dementias later on. So that the other important thing is hearing aids. People with hearing impairment, they are at a higher risk of developing dementia. There is a stigma about wearing hearing aids in our society. So if you find someone, or if you have hearing problems in your 50s, early 60s, go for a hearing aid, because the less stimulus goes into your brain, the more risk for developing dementia. So if you are not hearing very well, there is less stimulus going into your brain because of that. Similar with your eyesight. If your eyesight is not very good, but people don't have much of a problem going to see an eye doctor and getting your glasses fixed. But for hearing aids, there is a big stigma about that. I think that needs to change.
So many people see dementia care through a palliative prism. But the fact is that it's not really. I mean, I for one wonder how it can be palliative, because dementia patients can live even more than 10 years after they're first diagnosed. This is a misnomer, right, Doc?
It is a misnomer, and it need not be so grim. And in fact, many people are surprised when you have patients with dementia doing some of the things they were doing before. And that's something which you are consistently seeing. With proper treatment and proper support and guidance, people with dementia can do a lot of things. I'll give you some simple anecdote examples. We had a few cases, particularly one person with dementia who actually was a lady who used to cook very well. She used to enjoy cooking, and that's the passion, and that's something which she was very proud of. But unfortunately, there was a cooking accident when one day she kind of left the stove unattended, and there was a fire, and then the family just stopped her from going into the kitchen. And that led to a lot of deterioration over a period of time. But when we started seeing that patient and started advising the family to allow the person to go into the kitchen and supervise them, be there, but don't stop them from doing things. They can still cook to a large extent. Only thing, they may need some reminders now and then. If they're stepping out of that area, just make sure, check that the stove is switched off, or they're kind of removing things at the right time from the stove and things like that. So you advise them to kind of not, it's about positive risk taking. You need to take some risk and allow them to do certain things which they still can while monitoring them. There is a risk involved in that, but you kind of supervise that, and you kind of have some backup for that. You allow them to do that, and that actually sustains them for a longer period of time. And families are surprised that this person is still able to cook a proper meal with just a little bit of assistance. Otherwise, this person was just lying in the bed for over 6 months. They didn't allow the person to go to the kitchen. And she just deteriorated quite rapidly at that point in time. But allowing her to do things slowly, gradually, she started, of course, she can't cook independently like she did before, but she still can manage. And that actually improved her self-confidence. She actually thought that she was actually, she was valuable in that home. And that's something which many elderly face, that they feel they're not being valued. There's nothing for them. The roles, that the responsibilities that they carried out, they are no longer allowed to do that, and they feel that they shouldn't, are they being neglected, or they're being undervalued. But that's an image that needs to change. If you kind of
That's a
make them
very, very
feel,
important point. Like,
yeah,
aid don't ban, and make them feel wanted. Doc, is it okay if we stretch this a little more? I know we've already overshot our time, but is it okay if we take another 15 minutes,
yeah,
subject to
sure,
your
no problem,
availability?
no problem.
Like, Doc, now I was fortunate enough to have a sneak peek at your new Tambaram facility, and I think it's absolutely state of the art. Uh, are you toying? This was one of the queries raised by the caregivers. Are you toying with the idea of lifetime care there? Not now, but maybe later.
At this point in time, no, and probably that facility will not be an ideal place for lifetime care. The reason being there are only 20 beds, and lifetime care means, it's lifetime care. So that's going to actually occupy a bed for a longer period of time. And that means that we will not be able to, serve other people who need, um, you know, our service for a large number of time. So we hope that this will be a stepping stone towards kind of training people, enabling the families, enabling the caregivers to actually look after the person in their homes by reducing their stress, giving them some respite, and also setting their homes to a certain level. So getting some of the caregivers trained, and to come back and after the person when the person gets back home. Now, long-term care is something which definitely need in our community, and that's expensive, unfortunately. And that's something which, again, we need the government, we need other corporate sectors and other not-for-profit organizations. We all need to come together, and I don't think there's going to be one solution for this problem. It has to be multidimensional, multi-level solution, and that's the way forward. So we need to have services of different varieties available in the community. Uh, and the more intensive the service is, someone who needs a lot of input on a day-to-day basis, that service obviously is going to be expensive at some level. And the cost of that has to be borne by the family or by the state, either either of these two people.
It, as of
Now,
now, I think in India may be an ideal, maybe slightly idealistic at this stage. There's a question, Doc, tied to this on legal issues involved, and I'd probably take that question about how to manage legal issues that emanate when a person is diagnosed with dementia. One of the things that I often tell my clients is that you have a constitutional right that is not merely granted but guaranteed: right to equality, the right against discrimination, the right to life, which includes the right to timely medical attention. So if a hospital turns you away, they are in violation of that constitutional right. They are in violation of the Mental Health Act. There's a very clear provision under Section 21. You cannot actually discriminate patient with mental illness. Today, mental illness is also in the Disability Act, thanks to a lot of lobbying that went in, and finally saw the light of day. There are also advanced directives under the Mental Health Act 2017. There are advanced directives under Section 5, where a person an elderly person or person who's not too young, can come out as like a living will, and lay out the modalities as to how they wish to be treated should they be diagnosed with mental illness, or how they don't wish to be treated. So these are things which are there, but they only pertain to the mode of treatment. As far as financial implications are concerned, I think it's much simpler to actually, when you can, have at least one main joint bank account. If you invest primarily in fixed deposits in banks, ensure that it is payable to either or survivor, because you might reach a stage where the person who's suffering has money in the bank but is not in a position to use that. So either or survivor is a good way to have a good arrangement to put in place. Even if you're reasonably young today, it's good to open at least one or two joint bank accounts with both parties, or more than that, to jointly operate an account. Also, there's a lot of misconception about insurance, about medical insurance. In fact, a very leading hospital, the chief doctor the other day told me, the problem we don't admit because they may not be able to pay their bills. How will they pay the bills? Their insurance will not be entertained. That again is incorrect. Section 21(4) of the Mental Health Act very clearly says that medical insurance should be provided for all mental illnesses. The Insurance Regulatory Development Authority issued a circular on the 16th of August 2018, which actually said they have a statutory duty to supervise insurance companies. So if someone tells you there's no insurance, you can sue them. So I think these are some of the tips that I would give you as a lawyer as to how to deal with the financial implications. Now, Doc, coming back to your subject, does research indicate that music could perhaps help patients with dementia? My wife was, in fact, she had sent me a forward the other day on WhatsApp about how reciting Sanskrit slokas may also help. Do these things help, Doc?
Music definitely does help. There are lots of studies which are therapeutic. They do actually help in reducing the agitation, improving their well-being, and all that. So, in fact, we are currently pursuing a small study looking at music as an intervention for people with dementia. So, we're working with a couple of universities, one in the UK and one in Australia, to see how best we could actually deliver music as an intervention for people with dementia. So that's on the cards right now. So we'll be starting on that in the next few months. We'll be recruiting participants for that. So yeah, if any of you are interested, please do contact us. I'm more than happy to for that research.
Doc, another common query is, what are the different stages of deterioration in a dementia patient?
Yeah, it's very difficult to say that this is how it will be, and there is no prescribed.
Broadly,
yeah, it doesn't mean that it's definitely going to pass through these stages or things like that. But roughly, you'll have an early stage of the illness wherein the person is just having a few cognitive deficits. They may have just memory problems, just language deficits, or they may have just problems with conceptualizing or planning and organizing themselves and things like that. And that may translate to their day-to-day lives. They may actually make some mistakes in their cooking or banking. They may make some mistakes in giving out money to people and things like that, but they may be able to correct it with some assistance, with some help. So that's the mild stages of dementia that we commonly see. In the moderate stage, that the dependency becomes a little bit more. The more areas of the cognitive functions are affected to a larger intensity. They are more forgetful, they are more repetitive because of that reason. They seek more help for things. They can't function independently. They can't be going out alone because they forget their way. They're getting lost. They can't cook a meal like they did before. So that's your moderate stage of the illness. Now the next stage is kind of moderate to severe, and that's a transition which sometimes it takes longer, sometimes it takes shorter. That's when the person's personal care becomes affected, where they are not able to brush their teeth properly, they are not able to bathe themselves, they can't dress themselves, grooming becomes a problem, and things like that. And then eventually it kind of leads to a state where they're not able to eat properly.
Sometimes it may be unwillingness. We think is a case of unwillingness, but it's actually inability that they don't want to really talk about, right?
That's right.
When it comes to personal hygiene.
That's right. So it's kind of, there are two things happening. One is apathy. There is a stage wherein the person develops what we call as apathy, where there is a part of our brain which drives us to do things. So when we wake up in the morning, oh, I need to get up from bed. I have this thing to do. I need to go brush my teeth. I need to wash myself. I mean, there's something which does, oh, it would be nice to have a cup of tea. There is a part in our brain which tells us to do that. Now, unfortunately, when that area is affected, then we develop something called as apathy, where there is nothing much happening. I mean, there's nothing happening in our brain to stimulate us or telling us to do things. So the person just withdraws. They just don't react to anything. They just, in their bed all day. Leave them, they will just be there. They will be doing nothing. They won't even ask for food, if at all. So that's how that happens. The other thing which happens is that swallowing or eating is a complex activity. So if you look at a simple thing, you need to actually know something is in front of you which is eatable, which is a food. So that's recognition. The next part is you need to know how to eat it. The South Indian meal can be pretty complex to eat actually, because you need to mix things. You need to take the right proportion. You need to take a little bit of sambar and rice with a little bit of whatever side dish that you have, and then mix those things together. Take it into a thing in your fingers and take it to your mouth. And when you take it to your mouth, at that time your mouth has to open, and you shouldn't bite your fingers. And then you need to bite it, and then your tongue has to push it to the back of your palate. And at that time, the food pipe needs to open, your windpipe needs to close, and things go in. Now, it's a very complex set of things which we take for granted day to day. And when any of these processes are affected, they're not able to recognize something as food. Okay, that's why we advise make it really attractive as possible, make it colorful, make it attractive, and a lot of fragrance, and taste. Again, make it sweet as much as possible. Of course, limiting to the fact that if they have diabetes, you need to be careful about that, but make it as sweet as possible, because sweet is something which people actually relish a lot. So if they're refusing to eat, make it sweet as much as possible, within limits, of course, and give them that, and they may be able to eat it better. And sometimes people aspirate, they kind of put it in their mouth, and the windpipe also opens the same time as the food pipe, and then the food goes into the trachea rather than into the esophagus. And when that happens, they start choking and they start coughing out, and that leads to chest infections, a lot of complications. So there may be a lot of reasons why people don't eat, or it could be just that they don't like the food on that particular day. It's not their favorite dish, and they're just in a state of mind that they don't feel like eating on that particular day, and they may have constipation. Constipation is such a common problem. When someone is constipated, they just don't feel like eating. They may have some stomach upset. They don't want to eat on the day. To force them to eat on the day becomes a problem. They may start struggling, and they may start becoming aggressive and all that. So yeah, we need to make an assessment about why someone is eating or not eating.
I think the doorbell was an indication that we need to wind up. Thank you very much, Doctor. Absolute pleasure talking to you. I think if you were to contest elections, you will win hands down with your constituency, who are the caregivers here. So thank you so much. Thank you for being Dr. Sridhar, who's always been there for us, always so patient, so helpful, so caring. We really wish we could clone you and have many more Dr. Sridhars across the country and the world take care of dementia patients. Finally, ladies and gentlemen, I'd like to leave you with a poem by Owen Darnell, which was dedicated to his wife. Do not ask me to remember. Don't try to make me understand. Let me rest and know you're with me. Kiss my cheek and hold my hand. I'm confused beyond your concept. I'm sad and sick and lost. All I know is that I need you to be with me at any cost. Do not lose your patience with me. Do not scold or curse or cry. I can't help the way I'm acting. Can't be different though I try. Just remember that I need you, that the best of me is gone. Please don't fail to stand beside me. Love me till my life is gone. Thank you. Thank you very much. Back to you, Nivedita.
Thank you so much.
Yeah. Thank you so much, both of you. Just ending the live.
Thank you so much. Thanks a lot.
Thank you, Doctor. Thank you, and more strength to you and the DemCares team and all of you there at SCARF for the wonderful work you'll keep doing.